Just say test. You had two different
Video and the audio is
Turning to Ashley, can you hear me? Can you hear me?
They'll have to work around me. I mean, they can do
Okay.
the call or
Say
whatever.
something, let's see how long it takes before Ryan can hear me.
Something.
Okay, that'll work.
All right, thanks. She's here's background noise.
Oh, okay. Okay. That's
So it's
just like,
working.
yeah. Okay. Go ahead and start.
If it's just background noise, I just make sure that your mic input is correct. Make sure that your mic is correct. Test. It's coming through now. Here's your audio equalizer. So anytime someone's talking into it or picking up audio, this will show up. Say something, Annie.
Something.
Talk right into it.
Really? Do I need to move it? Testing.
Spikes up. That's how you know you have input through that microphone.
Well, can you pick up with it's right there?
Can you see it? Talk.
Can you hear me?
You're gonna have to talk a little bit louder.
Oh, well, I probably will. I'm trying to be quiet.
He confirmed yes, he heard that test. So
Okay. You ready to start?
Yeah, I do too. Yeah, I do too. Okay. Make sure you let everybody know that they have a smartphone and bring up.
Okay. We're good. We're ready to go. Okay. Well, welcome everybody. Thank you so much for coming. Thanks for showing up on this rainy day again. Appreciate it. And thank you to everybody who's on the Facebook Live. So we have some virtual friends. Hi, everybody. Thank you for coming tonight. My name is Annie Edwards. I'm the nurse practitioner here at the Intimate Wellness Institute. I am trained in family medicine and have had quite the journey to get here. Honestly, my background was in pre-hospital care, so I was a paramedic for many years, and then worked in ERs, and finally ended up in family medicine, which is been amazing and fascinating. I think through my journey, what I have learned is that women definitely get the short end of the medical stick. So it has really motivated me to be an advocate and to help, and especially for situations and things that we'll be talking about tonight. So we thought it would be fun to play off of Mother's Day. So our talk is "Oh Mama," things your mama never taught you. And I can say that's probably truthful. When I ask most women when their mother went through menopause, they don't know, because we don't have those conversations. So we're going to start having those conversations now, and we need to have them with our sisters, our friends, by the campfire, everywhere we go. I talk about it ad nauseum. I'm sure my friends love that about me. Who wants to talk about menopause tonight? I will say, on a more intimate or personal note, menopause means a lot to me. And I know that sounds really weird, but I feel like I went through menopause twice, honestly. And that sounds really ridiculous. Once when I was 15, and then again, I'm going through it now. When I was 15, my mother suffered greatly. And it wasn't just hot flashes. It was mental breakdown. And it was catastrophic. It changed my life. It changed our relationship. It changed everything. I went from feeling stable in my home to feeling very unstable and scared, honestly. And I wish she would have gotten the help she needed. And I wish there had been somebody who would have said, hey, there's help, you can do X, Y, Z. But who do we go to talk to about that? And when we do, oftentimes we're dismissed. So that's where we come in. And that's what we're going to talk about tonight. That we need to start this conversation, and we need to be doing this. So tonight we are going to talk about hormones, why you won't feel like yourself maybe, or your sleep and your mood. Why are you waking up at 3 in the morning? I call it witching hour. Super fun. Love it. Bladder leakage, urinary incontinence, desire, pelvic floor. I mean, going back to desire, who do you go to say, I don't have a libido anymore? Your family doctor? Who? Your psychiatrist? It's tough. It's tough to know where to go to get help. And oftentimes we are dismissed. And then we'll talk about options and things like that. So my question is, why didn't anybody tell us, that sneezing can be a pelvic event? Like, how many people cross their legs when they sneeze? That anxiety can be hormonal. We'll get more into that as we go along. That sexual desire can decline, maybe even go away, disappear, but it can return. And that leaking is common, but it's treatable. It's nothing we have to absolutely live with the rest of our life. Tonight, I wanted to make this a little bit more interactive. So we're using an app called Mentimeter. If you have your smartphone, get it out. You can go to the website called Mentimeter. Otherwise, your camera will click on the QR code. You can do this at home too, friends. And that way, I want you to be able to anonymously respond to some of the questions that I have. So we can see, I always say it, you're not alone, but I've never proven it. I've never shown you. And tonight we're gonna see that. So just know there's no pressure. You don't have to participate if you don't want to, but it will be really fun when we do. And then just knowing that it's anonymous, and you'll have some similar responses here. So when I think about this, I think about what we were taught versus what we should have been taught. We hear that a lot when it comes to the school system. Like, I wish I had been taught to balance a checkbook and change a flat tire. Maybe calculus wasn't my jam. I don't know. But here we are. Same thing with our health. We were taught, do you remember, like 5th grade was a rite of passage. We got to learn about our periods. It was great. It was just, I got to go to that class. I remember being kind of proud. And I remember feeling like I was a woman and I was progressing and growing up, We were taught about how to prevent pregnancy. We were taught about getting your pap smears, right? Like, that was important. We were taught about childbirth. You can buy any book about the topic. You can buy books about pregnancy. You can buy books about, when your baby, what to expect when you're expecting, what to expect the first year, etc. And then we learned that menopause is just horrible. That's all we learned. We were like, oh, that sucks. Well, we'll never grow up to be that old, right? Like, that will never happen to us. But what we should have been taught is that we have a hormonal lifespan. That we do have it's more to it than just starting your period and having babies. And unfortunately, in our culture, that's kind of how we're treated. Do you feel lost when you go to the OBGYN now? I do. The only one not pregnant, way over the age I should not be pregnant. I'd be in Tucker's getting some mental health support. We should have been taught about sexual wellness along with consent and pleasure and things like that, but we weren't. We weren't. I remember being taught, like, don't get a disease, don't get any STDs. We weren't taught about pelvic floor health and how to keep it strong. In other countries, they give you your baby and then they say, hey, you need pelvic floor therapy. Here, they're just like, all right, it's normal, it's part of life. Have fun with that, baby. And then you get so distracted and you forget and you leave yourself, and then things kind of go wear down and wear down and wear down. What we should have been taught is that menopause is treatable. You're allowed to treat it. And it's okay to treat it. It's okay to feel good. That's what we not want. That's what we need. We can be in menopause up to 40% of our life. So we need that 40% of our life to not suck, to put it mildly. So my first question here, hold on, don't scan that one. I have a better one for you to scan. Hang on. We're going to get to Mentimeter. So I'll give you a few minutes to get on this. Just give me 1 second. Yep. My first question is, what's one symptom you've experienced during menopause that you weren't sure was normal?
Can I just raise my hand?
I would love that. Yes.
Okay.
We have a friends on Facebook land. We have a non-tech, non-savvy person who wants to answer, raising her hand. Yes, ma'am. What is the number one thing that you did not expect for as a menopause symptom?
I'm not going through menopause.
You're not.
But I was just gonna answer it generically.
Yeah.
Yeah. No, I don't.
You're not going through
No,
it.
so I can't really relate to that part. But I was just asking for, you know.
Oh yes, future. Oh yeah, I thought you had. No problem. Well, have you heard anything that you were like, that's weird?
What you just said, the mental part.
Yes.
I was not familiar with the
Really?
mental
Yeah,
part,
the
you
mental
know,
part. Yeah,
and that kind of freaked me out.
yeah, it is. It is. Yeah,
It's scary.
it is. Yep, you'll see. I feel, thank you. I appreciate it. I feel like sometimes menopause is like the magnifying glass right over top of your anxiety or depression. You might already have underlying, just whoop, makes it bigger, makes it harder. So I see some really good, good answers here. Mental fog, itching skin. Oh, we see skin itching twice. That is that's a fun one. I just love that for myself when I get into bed at night and I feel like ants were crawling all over me. I had no idea that that was menopause related, but I was quite itchy. Exhaustion, dryness, not just skin dryness maybe, but vaginal dryness is a good answer. Yeah. Joint pain. So a lot of women get diagnosed around this time of our lives with frozen shoulder and other ailments that are related to the joint pain and the muscle pain. Not there yet. Lucky. These are really good answers that show us like that there are a lot of umbrella symptoms that could be mistaken by other providers. So if I were to go to you and say, I'm so depressed and I'm so anxious, and you were to help me, it would be compartmentalized, right? And then if I said, oh, I have heart palpitations, which is also another symptom, I might get sent to a cardiologist. But it's a whole cascade and umbrella of symptoms that really need to be treated as such.
Go to the cardiologist.
Right. Let's rule out any major problems.
Yeah.
But if you've gone and they've said there's nothing wrong with you, here we have another issue, another symptom that maybe you weren't quite sure was related to menopause. Oh, all right. Thank you for everybody who participated. All right, moving right along. So just like we talked about in that last slide, so some things that your mama never told you is that hormones affect almost everything, from weight gain, like we said, things we didn't know, the itching skin, all that. I'd say the number one complaint or concern that I hear at the first day that I meet somebody, I don't feel like myself. I don't feel like myself anymore. Yeah, along with the hot flashes. And I think we have this idea of how hot flashes go. Like I remember my aunts being really sweaty and red, and I didn't want to hug them. And that's the thing. And that's kind of how I thought my hot flashes were being. It wasn't, my hot flashes were nothing like that. I noticed subtle changes, like I would eat spicy food or drink a hot drink and get really hot, like unusually hot. And that was for me, my hot flash. So it can change everything. So the myth we need to bust is that it's not just an estrogen deficiency that you have to suffer through. There are solutions. There are all sorts of solutions to these issues. So I'd like to know who here wakes up between 2 and 4 a.m. Dr. Guerette's going through menopause too. It's fine. We won't tell anybody. Let me just switch to the next slide so you can get. Oops. Am I out of order? Hang on. There we go. That's the one I want answered. Yeah. There are a lot of regularlies. I mean, look at that. You're not alone. occasionally. Yeah. Lucky is the people who never ever wake up between 2 and 4 a.m. It's something that I jokingly call witching hour. Start waking up at 3 in the morning, and it's a moment where you have ruminating thoughts that just won't stop, and you can't soothe yourself back to sleep like you once did. Maybe even intrusive thoughts that you're like, why am I even thinking about that? Why? Okay, the end of the world, or world hunger, or whatever, things you can't solve, and it just goes through your mind and you can't shut it off, and you can't shut it off. That is definitely a sign. So yeah, a lot of us here are having, that's fun. Come talk to me if you're having that situation. I know it very much impacted my life. So I had to be up at a certain time to go to work, right? And then I had to drive, and then I was exhausted, and then I had to perform during the day. And how could I when I was sleep deprived? And not just one night, but over time, you're in a sleep deprivation cycle, and you're losing hours of sleep, and it just keeps compounding, and can compound these symptoms. So if you are prone to depression or anxiety, it's likely going to make it worse. You know, if you're having brain fog and you're also sleep deprived, it's most likely going to make that worse too. So this is why sleep is so important and can be interrupted by estrogen deficiencies and other deficiencies during menopause. All right. So vasomotor symptoms, what are they? We talked about them a little bit. Vasomotor symptoms are hot flashes and night sweats. So during this transition, during this time, like 80% of women have it. But it varies. So before menopause, hardly anybody gets them, 21%. You know, maybe when you're a little bit younger and you're going through some fluctuations, you might have them every now and again. By perimenopause, we have 41%. That's a lot. A lot of people. That's a lot of people having that. And then post-menopause, 42%. So it looks like it kind of bumps up a little bit even after we start our periods, and can last for some time. So my next question is, how long can vasomotor symptoms last? Oh, it's not changing for you? Sorry. Where's Ashley? Yeah, I need you. Sorry, just some technical difficulties here. Oh, is that what happened?
I apologize, guys. One moment. Should connecting now. It should go.
Yeah, we should just play our, yeah, pause this moment.
Here it is. Hey.
Thank you. Just sit close by. How long, yeah, how many years on average can vasomotor symptoms last, do you think? Yeah, most everybody. Yeah, so on average, anywhere from 7.4 to 10 years that we can have vasomotor symptoms. That doesn't sound like much fun to me. And here's a fun fact. Not only can they vary, but they can vary by race. So African American women have on average 10 years of vasomotor symptoms. Hispanic women 8.9. Non-Hispanic white women around 6.5 years. Chinese women, 5.4 years, and Japanese women, 4.8 years. What can also contribute to that is a poor social situation or a higher BMI. So that can also contribute to, you know, worsening of those vasomotor symptoms, that those hot flashes and those night sweats. Yeah, and then there's a very small, unfortunate population group who experience these for more than 20 years. That would be awful. So again, I say that to say, get the help you need. You don't have to suffer through this. And as we can see, and most of us knew, it's not just 2 years or 3 years. It's a really long time. It's a really long time to deal with that. Because it's always fun to be standing and giving a presentation or talking to somebody and you just start sweating, right? Like that's a great feeling. All right. And this is what leads me to this. Again, every treatment program that I put somebody on is tailor-made. It is not a cookie cutter, because you're not a cookie cutter. You're different. We can see that race factors in, your health factors in, your medications factor in, so, and your personality and your lifestyle. So I'm not a person who's really great at taking medication every day. I'm just not. I don't remember. I get too busy. So if somebody were to say, hey, you need to do this every day, I might not. That's me. So I opt for pellets. I really like pellets. It's this that old set it and forget it, like a crock pot. I get pellets and I don't have to worry about much of anything. It delivers the estrogen and the testosterone I need over time for at least 3 months, and I'm good. But then there's some people who want to have a little control over it, right? So they like patches for estrogen and they like cream for testosterone. So there's so many different options. And again, tailor-made for your lifestyle to how you feel. So when it comes to your treatment plan, you know, we would bring you in, talk to you about your symptoms, what's going on in your life, do your labs to get a baseline, because we can't always capture it perfectly, right? So from day to day, everything can change, but it's a good way to start and to see what's going on. Usually we bring you back and we have a conversation looking over your labs and say, hey, what would you like to do? Here's your options. How would you like to treat? And that's how it usually goes, so that I can know that you're on board and that we're making shared decisions together and that you'll be happy and feel better. That's the goal. Most important is how you feel. So we're gonna switch gears a little bit here and talk about leaking. Let me advance here. Wow, that's impressive. I mean, I don't even have to say it. Look at that. That's most of us. Maybe even in this room, maybe out in Facebook land. That's a lot of people having that symptom. And I will say, as a young mother, we used to make jokes about it. We would have that little leak when we sneezed, and we thought it was funny. We just thought it was part of life. It's not. I mean, it is. It's very prominent, and people have it, but it's treatable. So know that you're not alone, and there's a lot of it going on here. So we need help with that. Don't just let it slide. So again, like I said, mama might have told you, mama might even have problems with it. She might have told you that it's treatable, and all the different types of urinary incontinence there are, like stress incontinence. Just like we asked the question, do you have to kind of cross your legs when you sneeze or cough? Do you avoid the trampoline park now because you wouldn't be caught dead jumping on a trampoline because things would happen? That would be stress incontinence, leaking during coughing, sneezing, exercise, laughing too hard, things like that. Urge incontinence, sudden intense urge to urinate. Just let's say you're in the kitchen, you start washing dishes, the water runs, and then you're like, woof, or you're standing too close to the bathroom and your brain goes, hey girl, it's time to go. You got to go. That would be urge incontinence. And then there can be a combination of both. And then overflow incontinence, which is a little bit more difficult to, we'd have to examine and do some testing to see if that's what's happening, meaning your bladder's not emptying all the way. So you're going and you feel like you're going out. So your bladder's holding all this liquid and then you go, but maybe it's just a tiny bit and not all. And then so it's getting so full that you leak a little because it's over full. And then there's functional incontinence. I think most of us can understand this. Somebody in a wheelchair, let's say, or you recently broke your leg, or you have a mobility issue and you just can't get there in time. That's a little different. All right. So what makes us at risk for this? Aging and menopause. Lots of receptors down there for the estrogen and the testosterone. Those receptor sites they're hungry. They're empty. Our estrogen and testosterone have declined. Pregnancy and vaginal childbirth, obviously, goes without saying. Obesity, so a constant pushing down and stress on that area. Chronic coughing, so somebody who has like really bad asthma, COPD, something like that, who's constantly coughing will most likely leak a whole lot too. And then neurologic disorders, so brain disorders. And then anybody who's had a pelvic surgery. So it kind of puts you a little bit of risk sometimes, not all the time. Our pelvic surgeries help. Yeah, exactly. Here's another question for you. Do you mentally map bathrooms everywhere that you go? I like it. I should have put that in. Not anymore. I used to, but not anymore. Yeah. Yeah, that's tough. It's a lot of women that I talk to who've had this problem for years, and then I meet with them because they're scheduled for surgery to correct this problem. It's amazing the hope that they feel. They're looking forward to not knowing where every bathroom in Chester Hill County is. Or, a lot of them have said, I go on walks with my girlfriends. They don't even walk with me anymore because I have to stop them in the bushes, or I have to, I can't go as far because I just, my bladder. And it's so amazing to see people get their life back, because this takes a toll on your life. This is a poor quality of life, always worrying about leaking, always worrying about where the bathroom is. What if you do leak? What if when you leak, somebody can notice? What if when you do leak, somebody can smell? What if, how much do these things cost to absorb the leakage, whether it's the pull-ups or the pads? There's so much that goes into it that what we see is a lot of women become really isolated. So you turn down that invite to go somewhere because you don't want to be the one getting up, going to the bathroom all the time. Or you turn down that invite to go on that walk. And now you've started isolating yourself. I've even had patients in the past who would not get the medical care that they needed. They needed to be on diuretics because of their heart. That's important. But I had a patient once tell me, and she cried, she said, Annie, if you put me on that medication, you might as well put me in a nursing home because I will never stop urinating on myself. And I already feel terrible enough about it. I can't handle this. I will not be okay. And she declined against medical advice, against the cardiologist's advice, because she knew it would adversely impact the quality of her life. And that's just sad. And sad too, when we know there's help. And sometimes it's just a little tweak. Sometimes it's a big tweak, but there's hope and there's help. So you don't have to live that way. So again, like I said, sometimes a little tweak, sometimes a big one. So we can go from conservative to advanced. Sometimes as simple as pelvic floor therapy. Do your Kegels. Do your Kegels, friends. We should always say that. Our mamas taught us, say your prayers, eat your vegetables. I would add in, do your Kegels. Do them. So there's biofeedback. So there's things that you can buy, devices that you can buy that kind of gives you some feedback on how hard you're squeezing, if you're squeezing, how much you're squeezing. We have the Emsella chair, which is this picture down here. We have that here. Lovely. I love it. That is probably my favorite. I wish I would have invented it. I'd like to meet the guy who did. I would shake his hand. So you sit on that chair. As you can see, it's non-invasive. So nothing goes into your body. You sit there with your clothes on, and it does the Kegels for you. So in a 28-minute period of time, 11,400 Kegels, just you sitting there. I love it. And you can feel the difference. Usually a treatment is twice a week for 3 weeks, and then you do some, I call it maintenance or tune up every 6 months or so. It's fantastic. Sometimes medications can help with this problem. Sometimes, surgical interventions are what we need. A lot of times they are. This little device that you see here is an interstim. It's a little device that helps with some people, with some problems, the body to sort of communicate with itself, to know when to go. It helps with overactive bladder. It's a lot loosely described as a pacemaker, but for the bladder. So it's helping with that. There are options. So we're going to switch gears again and talk a little bit about intimacy. Be like, no, nothing's changed. So yeah, it's multifactorial again. So intimacy, not only in terms of your hormones in decline, where you get to the point where you're like, don't even touch me, don't look at me. But it can be many different things. Maybe a leaking problem with the urine and you just don't feel very attractive. Maybe a weight gain you weren't anticipating and you just don't feel as attractive. Could be your partner, obviously, right? Could be life situations, circumstances, stressors, but also can be physical. So if you're having pain with intimacy, you're less likely going to want to participate, especially if you're not getting anything out of it. It's a big investment for hardly any fun if things aren't going well for you. So we see that you're not alone, and it varies. And from my perspective, I see it a lot with the hormones. As the hormones decline, the intimacy of the libido also goes with it. So most time I'll ask women, how's your libido? And they'll say, it's not even there. Not even there. And it puts a strain sometimes on relationships, for obvious reasons. Can make you feel a little bit more stressed. Again, we're mothers, daughters, sisters, coworkers, workers, friends, everything, caregivers, all of that. And sometimes it's just one more task to have to do. And it shouldn't feel that way. It should feel good, and you should be happy, and it should make you feel just as good as anybody else. And so just thinking about all the things that can contribute to it, whether it's pain, leakage, hormones, we can correct that. There's hope. And it looks like we're not alone. There's a lot of people who just feel like, yeah, things have changed. It doesn't have to be that way. I have a lot of women say to me, it's just my age. I'm not supposed to be doing that. I don't know what book they read, but it was like, burn that book. I don't think that should change ever. It should be something that we enjoy, and it's a good time for us to reconnect or connect with our partners or ourselves. So again, that we hear all the reasons I just mentioned, that it can be painful. You can feel dryness, which can make it painful, a pinching, burning sensation, almost a tearing sensation when the vaginal walls and the vagina are dry, and they can get dried out from lack of estrogen. And it's almost too, our bodies are almost use it or lose it. So if we're not stretching, pushing, if we're not having sex, we can sort of atrophy a little bit or just sort of shrivel up. We don't want that. Arousal changes, orgasmic dysfunction, and like we said, or relationship impacts is what it can lead to. Sometimes I have people who come in just because I can't get aroused anymore, or I can't achieve an orgasm, or it's not the same. Who do you go to talk to about that? I mean, I just think about people who, where do they go? I mean, I can't imagine going to my family doctor and being like, hey, I'm having this issue. And then say, oh, no, look, I just want to take care of your blood pressure. Ms. Edwards, like, we're not going to go there. Or even go to your OBGYN. I hear a lot of women say, I feel pushed off or brushed off, or I'm told this is normal and this is part of aging, like get over it, just move on. And they're completely dismissed. You won't be dismissed here. It's our specialty. It's what we do. Make a lot of people happy. Every day I hear my husband says thank you. I'm like, good. Tell him you're welcome. So there's hope. This is a good question. Have you ever had some point of pain occasionally with intimacy? Yeah, that's telling. Most of us. Yeah, most of us. Let that sink in. It's nothing to be embarrassed about because it's most of us that we've had that at some point, no matter whatever it was going on, at some point we've experienced that. Now imagine having that with every experience chronically for years and years to the point where you're like, this is just not for me anymore. Especially at younger ages. And I think it's sad too, because we don't talk enough about it. Who can we go to? I cannot imagine going to my aunt, my grandma, my mom and going, hey, is sex supposed to hurt? You know, mental health, we have a lot of religious trauma. Sometimes that can impact us. And we might feel shame to talk about this, but we should not. It's a healthy, normal part of life. And it's an important part of life. So the fact that we all, I mean, that's 100% if we answered, have that problem tells me it's a big problem, but a manageable one. That's the thing. I have so many women who have suffered in silence for many, many years. And then when they get the help they need from Dr. Guerette, and sometimes me, they'll say, I wish I would have done this sooner. I wish I would have addressed this sooner. But I can imagine for some people, including myself, I don't know how comfortable I would be going and like, who do I pick? OB, PCP? I don't know. Is there a person who does that? Yes, there is. He's sitting right there. And I'm standing right here. Yeah. So comfort matters. Like I mentioned before, as the tissue starts to decline, as the estrogen starts to decline, the tissues can be thinner and drier and more sensitive. And I imagine the little plants I have at my house that I forget to water. It's just like, that's how it kind of goes. So then you have that dryness and the burning and then the pain with sex. So it just needs that estrogen to sort of water it and come back to life again. It's amazing what we can do to rejuvenate that tissue. There's so many different options. We don't like the tearing. We don't like the irritation. Sometimes the vaginal dryness can lead to frequent UTIs. Oftentimes it does. A lot of times it does. And then, of course, lower arousal because your body's trying to protect itself. It knows it's like, oh, this is going to hurt. So then you go into that mode and you can't relax. And then how can you have any fun like that? So when it comes to libido or intimacy issues, you have to clarify your own goals. You have to know if it's a problem for you. If it's not a problem, it's not a problem. But if it's causing a problem for you personally, or even maybe your partner, it's time to get help. It's time to address it. So you need to clarify what your goals are. Oh, it happened again. Sorry. Thank you. apologize. We'll have this little moment.
14 the ads. Okay, there we go.
Thank you. Thank you. Thank you. Okay, so clarify your goals. Get clear on what it is you want. I mean, do you want to be like you're 20 again? Do you, or better? Do you just want to have peace surrounding that, feeling good, being relaxed? And then realizing, is this really distressing enough to me? And if it is, there's no shame in that. That we would review your medications when we spoke to you, because sometimes medications can impact these things, whether or not you're sleeping. Again, going back to the hormonal issue, if you're not sleeping, you're not really going to be in the mood for much other than sleeping, right? You got to catch up on that. Stress and sometimes relationship context. So mental health provider, right? You would know, you probably hear about that a lot. So sometimes it is within the relationship, but you have to get clear on that and know. So what we would do to evaluate you is also to do a pelvic examination and just determine whether it's structural or is it a tissue issue. Are you having, thinning of the lining? Is it becoming more dry? Sometimes I've had women feel like it wasn't. They'll be like, I'm not dry. And then upon an examination, they are. And then when we start treating them, they're like, oh my God, my life changed. I feel so much better. This is so much better. But again, we don't talk about it enough. So how would we know? We really don't have much context, do we? Nobody says this is what vaginal dryness feels like. It's almost like we have to experience it. It could start, you could notice it during sex as a pulling, tearing feeling, but I feel like that's pretty late. It could start as like a dull itch or ache or stinging feeling. It could feel like, my underwear irritating me now. It never did that before. Oh, I'm sensitive now to pads, or I'm sensitive to a type of material. It's very subtle sometimes. But then when you start getting more UTIs or you start having symptoms, then you know it's probably vaginal dryness. We would do labs again for the obvious to check to see what your hormone levels are doing, if that's contributing. And then again, a shared decision-making plan. It's between you and us. And within that room is sacred space. You can talk about anything. Trust me, I have 4 daughters. I've heard it all. I've heard it. You could probably not shock me. I can't promise that my face won't turn red, but it is what it is. But I've heard it all. And I'd say after several years of few years of Dr. Guerette doing this, he's heard it all too. So it's nothing shocking. That is a special place. Where else can you go to say, I don't like it when I have sex, it hurts now. And it never did that before. Here with us. All right. So there's lots of treatments. A layered plan is probably the best. So there's probably no, knockout, like this is going to be the best, this is going to treat it all. It's probably going to be a layered approach. You might have to do a few different things. So from pelvic floor support to getting those hormones right, to improving your sleep. That's important to me. A big sleep person. Physical corrections to therapies to restore the tissue. So getting the estrogen right in that area. Localized hormones like vaginal estrogen creams and energy-based therapies. We have lasers here. I like the way Dr. Guerette explained it the last time we were here. He was like, not like a cutting, like not the Star Wars laser, right? Was that a Star Wars laser? But like the kind that's therapeutic and rejuvenative. And then we have this lovely support called the PRP, which is amazing. What is the intimate PRP? So it's a rejuvenative treatment that uses your own body's platelet-rich plasma. And I'm sure Dr. Guerette will go into this a little bit more, but it's fascinating, it's wonderful. And I have many people who love this therapy. So it helps with sensitivity, orgasmic function, just feels so much better. So what we do is we take some blood from you, spin it down. That gives us that what we call PRP, that platelet-rich plasma, and then we inject it into that special area. And it's over time, it just helps with your growth factors, helps promote, helps rejuvenate. What I love about it is there's really not much downtime. We do it here in the office. It's easy, it's quick, you're done, and the results last for quite some time. And it is a lot of A lot of women just love it and they feel so much better with it. I feel like we don't talk about this enough, but I know Dr. Guerette's probably going to go into this a little bit more. All right. So here's an interesting question. I think this is the last question. I'd like to know if you've been to a provider to get help. What is something that somebody has said to you or a provider has said to you that made you feel completely unheard? Oh, I love these. Thank you so much for this, because nothing we can do for you. You're seeking help and somebody looks you in your face and says, there's nothing we can do for you. Sorry. You're too young. I've heard also you're too old. Your lab results are normal. Yeah, that's a little frustrating. Lose weight. Oh, I would probably take my shoe off and throw it at somebody if they said that to me at this point in my life. If it were that easy, we'd all be thin, right? It's part of aging. You're just getting older. It's normal. That's just part of it. Get over it. Nothing's wrong with you. Try drinking more water. I feel like that's my favorite. Try drinking more. Wow. I wonder what kind of water they have their practice. Yes, I haven't had that water yet, especially if it were going to help me intimately. Like, please bottle that and give it to me. I would love that water. So yes, there are some very dismissive examples up there, and we've all experienced it, including myself. I was having an issue and went to a trusted OBGYN, and this is just a personal story. And I said, I think I have a prolapse. And they said, when they answered, this wasn't the provider, this was the person who answered the phone. And she said to me, what is it that's coming out of you? And I was like, well, it's not labeled, so I'm not sure. I don't know. She was like, how do you know it's your vagina? I was like, pretty sure that's where things are coming from. And she said, well, you're going to have to go to patient first. If you're not for sure it's your vagina, it's definitely my vagina. Well, we'll squeeze you in then. Very, very angry with me. And we just don't have time for this. And I was like, oh, okay. That's how I was spoken to. And then, of course, I get the appointment that day. I get the exam. It took 3 milliseconds. Nothing's wrong with you. Everything's fine. Gesticulate. Okay. So I know how it feels. And I have been dismissed, and for lots of different reasons. I was dismissed as a young mother. You're too young. You don't know what you're doing. And now you feel dismissed when you're not no longer going to have babies. You go into the OBGYN again, and it's like, what are you doing here? This should just take a second or two. And so that's pretty common, unfortunately. So again, I ask, where do you go? And I think that's the biggest question that a lot of us have, like, I'm having these issues, I'm being dismissed, so maybe I am crazy. And that's sad that we're made to feel that way. And I feel like a lot of us women are made to feel that way. I mean, I've even had wives bring their husbands with them to their appointments to prove to the husband that menopause is real. And there's a part of me that's like, that's great. And there's a part of me that's like, really? It's not an excuse. If we could feel better, we wouldn't choose that. We would choose to feel better. So we have a lot of that in our society and in our lives as women, where we've been dismissed by family members. We've been, suck it up. I'm having period cramps. No, you aren't. I was told mind over matter. That's not really true. That's not really happening to you. And then as you think you're going to go to the medical community and you're going to get the help you need, and you're going to be heard, and you're told drink more water. So, wow, thank you all for sharing that. That's amazing. So I like to ask the question, what if we treated women like they deserve to feel? And how do we deserve to feel? We should feel happy and calm, reassured and confident. We should feel at peace with our own bodies and not like we're fighting a war with our own body constantly. So you're not just meant to simply tolerate these symptoms, no matter what they are. We offer all of these things that I just went over. Dr. Guerette will get into a lot more of what we have here. And then I'm just providing some resources here for you. This is our website on this QR code, so I'm pretty sure most of y'all know how to get there. And anybody have any questions? Anybody in Facebook land have any questions or comments? Nope. Okay, good. All right. Well, we can do it at the end of your slide. You have a poll. I just put that up at the end of yours. Okay. We'll just do yours first, and then we can do that. All right. So quick break. Thank you, everybody, for coming, for everything. Dr. Guerette's gonna
Go get some food or drinks or
go to the bathroom. All right, just a quick little break, and we'll be right back. Oh, is it dying? Is that why I was doing that?
It might be, but where's your card?
My computer worked hard today.
Right, that's for Dr. Guerette. He's gonna use this one too. You wanna put it on him? I can't with my nails.
What was your name?
It's Walmart.
I got it a lot.
I'm gonna try not to get in your chest here.
Oh wait, that's the wrong one. There you go.
Where's the other part to it? Oh, it's.
This is the clicker.
No, where's this going?
It's wireless.
Oh, okay. Got it. How do I get to the intranet?
Can you
Oh,
help
you
him?
on
Yeah.
And then maybe disconnect.
just need to
so
get
you
the
can-
Google Drive.
yeah.
No,
Disconnect maybe.
okay. Hold on.
I know he sees his password.
Yeah, that's true.
That's true.
Thanks, Walmart.
Where is that? Oh, I see.
Let me know when you're ready for me to.
Yeah, I got it. Oh shit. No thanks. I don't need it. Stop. Just go away. Okay. All right. Very good. So where do I want to start? I'll probably start with these. Awesome. Turn it on.
You're trying to scroll. Ready?
Yep. How do you think?
Where you gotta go. Search. You prefer to extend display? We're gonna go to advanced display. I lied. You're not gonna go to advanced. Multiple displays. Connect to a wireless.
intuitive.
It is not streamlined by any means. Showing you're good to go.
Nice. Yep.
Oh, this one.
Yeah, a question? Okay. All right. We'll do question during intermission. Go ahead. Huh? Sure, we can do, yeah. Right. We can do that. Yeah, I don't need the lip gloss. Yeah, no, I'm good. I go without the glossy lip. Hmm? Super tall. Yeah, is that what Tatiana is? Well, this probably best thing to do is to read the, like, we could read the question and then give the answer. Well, is everyone back? Or? Everyone, yes? Are we all back? All right, let's get started again. First, happy pre-Mother's Day. Thank you for all making it out, especially on a rainy weekday night. So we appreciate your guys' interest in coming. I think before I start my session, we had a question at the conclusion of Annie's. So if we could just read the question out loud so everybody could know it. If I was treated for endometriosis, we would have serious problems. But endometriosis can coexist with PCOS, but they're separate disease processes. Right now, I'd have to say PCOS is being massively overdiagnosed. It seems to be the popular garbage diagnosis du jour. If someone is diagnosing you with PCOS, you need to have actual proof that you have PCOS, and that means you have to have certain symptomatology, so body changes, and also labs that would be consistent with it. I think oftentimes PCOS is just being used as an excuse. It's an acronym for I'm not sure what's going on, but we're going to label it with something. But to answer the question shortly, yeah, they can exist together. They have different symptoms. PCOS doesn't cause pain. PCOS causes weight changes, insulin resistance, acne. Oftentimes symptoms associated with high testosterone levels. It can cause changes in your body in that regard, so hair growth, clitoromegaly, things like that. So it doesn't cause pelvic pain. That would be more associated with endometriosis, particularly if it's cyclic with your menstrual cycle. So. Any other questions, or should we proceed? Okay, so I'm Dr. Nathan Guerette. I'm a urogynecologist and pelvic reconstructive surgeon. Most people in the room know who I am, but those out there, I don't know. I am the CEO owner of the Intimate Wellness Institute. We're a center in Midlothian, Virginia, so Richmond, Virginia, and we specialize in urogynecology and intimate wellness and all things related to that. Annie did a fantastic job, I think, kind of trying to show how we're different in how we approach things versus traditional women's health that tends to just focus on standard gynecology or obstetrics. And doesn't focus on these types of issues and quality of life issues at all. Um, medical training, even up to the level of fellowship training, does an absolutely horrible job in terms of quality of life issues. Urogynecology is probably better than most because dealing with pelvic support issues, incontinence issues is quality of life, but even still, most urogynecology practices just focus on their little area in terms of incontinence and prolapse. They don't relate it to entire pelvic dysfunction or your entire body's dysfunction that go along with these types of symptoms and have much less holistic approach than we do. So what I'm going to do is actually get unholistic. So Annie did a fantastic job getting holistic. I'm going to drill down on some of the more advanced and some of the more unique therapies that we do here to just talk to you a little bit more in detail about those so you could have a deeper understanding of them. So first thing I'm going to talk about is energy-based therapies for the vulva and the vagina. So when we talk about energy-based, what we're talking about mostly is lasers. And lasers come in all different types. And then also the other common modality is radio frequency. We have both. We have two different lasers, and we have actually three different radio frequency devices. So so we have the widest array of any of these treatments definitely in this region, anywhere that I know actually. So when you talk about a laser, right? Annie alluded to this slide, but I love this slide, so I use it any chance I get. So this is what people think about, right? They're like, "You're going to do what to where?" Right? You know. So, but this is not what's going on, right? So what a laser is a means of delivering energy in a controlled way. And what we're doing is it's a resurfacing laser, which causes remodeling to the tissue. The depth of these treatments is barely deeper than a sheet of paper for most of the treatments. So we're not talking about blasting deeply into the tissue. We're talking about causing positive changes to the tissue in a way that actually doesn't hurt at all. The other common reaction is when people hear lasers, they think, oh, you know, this is like only for fancy people and only for, you know, Beverly Hills and celebrities, and they get it for free because they say something on, you know, Facebook. But that's also not true, right? These are functional treatments for real life daily problems that everybody suffers with, and these are not therapies that you have to think are not appropriate for your normal person in Richmond, Virginia. You know, these are for everybody. In terms of the need, the types of things that we can treat with energy-based therapies, vaginal laxity, so looseness, so after having kids or just with age or sometimes just tissue changes, you can start to develop a loss of connective tissue and muscle strength in that area, which can lead to loss of sensation with sex because there just isn't any contact with the tissue any longer. It can also lead to other functional problems as well, as basic as vaginal infections because the tissue is too open, constant irritation, UTIs as well. And so when we talk about laxity, it's not really formally prolapse yet, which is a more profound loss of support in the pelvis, but it can be very significant for people, particularly with sexual dysfunction. And the treatments are fantastic in terms of rejuvenating the collagen, elastin in the tissue, tightening the tissue, and with no downtime. Right? These are just regular office treatments. You come in, you get it done. There's no discomfort. We use an excellent topical anesthetic. You don't feel anything at all, and the recovery is just 2 days of feeling like you have a little bit of a sunburn in a weird area, but that's it. Dryness is probably the most common reason we use it. So the technical terms of vulvovaginal atrophy or genitourinary syndrome of menopause, that's the more PC term, but you can't say that more than once without your tongue getting tired. So it's atrophic changes, which are normal changes with menopause, but we're not meant to be on this planet as long as we are on this planet now, right? The average age of a human being is about 40 without modern medicine. So we're living way, way past what our bodies were ever designed to do. So we need things to help us to live a high quality of life as we get older, because otherwise we're just going to be sitting there miserable for half our lives. That's no good. So there's nothing normal about anything. When we talk about, well, this is normal, there is nothing normal after 35 years old anymore, right? Nothing. Like you're past what normal is, because everything that exists in our society and our science has allowed you to get to that point, right? Otherwise, we would have died of pneumonia when we were 20, right? So this is all different stuff, and so there's nothing wrong with seeking help for these problems, just like you would seek help for maintaining your cholesterol or anything else we do for allowing us to have a healthy, continuous life. Urinary incontinence, super common, right? We'll talk about that a little bit more. Mild prolapse, that's the loss of support. Orgasmic disorders, these therapies help with. Vulvar dystrophies, which are skin conditions of the vagina, the most common one being lichen sclerosis. I'll talk more about that. Dyspareunia is a fancy way of saying painless sex. That helps with that, and then also aesthetic changes and also scarring. So sometimes obstetrical trauma, or God forbid any scars associated with surgeries I do. We try not to ever have any, but it's inevitable. Surgery does cause scars, and sometimes those scars can be uncomfortable. These therapies get rid of that discomfort. It can help with an enormous number of things. Prolapse, super busy slide. Do not worry about the details. This is data abstracted from the Women's Health Initiative study, which was a huge study done in the early 2000s. They actually also looked at pelvic support. And what they found is 2/3 of women after menopause have at least a stage 2 prolapse, which means at least things are coming down about halfway. So your bladder's coming down about halfway, your rectum's coming down about halfway, top of the vagina, uterus. So stage 2, which is typically when things start to get symptomatic, over half women after menopause have that. So extremely, extremely common problem. Vaginal dryness, even in early premenopause normal women, it can be common. 4% is probably an underestimate. Women on birth control are often an overlooked population with this. If you are on progestin-only birth control, so an IUD that has progesterone in it, Mirena, or any of the other versions of that, or the implants, Implanon, things like that, or progestin-only birth control pills, you have no estrogen. Your estrogen has been shut down. So you are essentially equivalent to a non-estrogenized postmenopausal woman. And you start having the same symptoms. But nobody thinks about that. You come in, you start having painless sex, you start having irregular menses, other things. No one in regular medicine ever thinks, you don't have any estrogen, and they don't give any back, and it just goes on and on. But so that's a massively overlooked population of patients. But once you get into postmenopause, menopause is just the moment your ovaries stop. It's that instant in time your ovaries stop. So really what we're talking about is perimenopause, premenopause, perimenopause. Menopause is that instant, and then most of what we're talking about is postmenopause, right? If we're being technical. In terms of postmenopausal women, dryness is extremely common. So dryness, irritation, atrophy, extremely common problem. Pain with sex is an extremely common problem. So in terms of the general population, about 20% of women will have pain with sex. About 50% will report on occasion. If you get into more pathology-related populations, so in premenopausal women, pain with sex is about 30%. In postmenopausal, it's over 50%. In our population of patients, it's 60-70%. If you get into women who have been treated with breast cancer, so they can't have hormones, they've been deprived of hormones for a long period of time, that's 60-70%. Actually, I've seen studies as high as 90%. And that's just because the tissue has been destroyed. And necessarily, right? If without doing that, you wouldn't be here. So okay, but let's deal with it. Let's there's no reason you have to suffer. We can fix that. So you're here, awesome. Now let's get your quality of life back, right? There's also a heavy toll on quality of life in terms of relationships with this. So if you can't have sex, if you're not having sex, that is going to impact an intimate relationship over time, inevitably. No matter how good everything else is, it will eventually erode that relationship very, very significantly. There's just no way around it. We have lots of friends. We don't have a lot of intimate relationships, right? Or at least most of us don't. Right? And no judgment. It's just, but most of us don't, and so there's something unique about that. And if that's lost, the relationship typically gets lost too. All right, so just a little talk about anatomy. All right, this is what you see in the books. Fine, but it doesn't tell you anything. It just tells you where things are. In terms of what really matters, this is a diagram showing pelvic support. Let's see. You had a dot. How'd you get that dot? Yeah, your dot, your blue dot. Ah, there's a dot. Oh. All right. Anyway, so the connective tissue in the pelvis is like a suspensory system. All right, so you have ligaments that hold the top of the vagina and the uterus in place, and the uterus is held at the level of the cervix. It makes sense if you think about it, because the top of the uterus has to get enormous during pregnancy, right? And if it was fixed in place, you'd be in agony. As it is, you're already in agony, but you'd be even more agony. And so it's held at the bottom. And so those ligaments are called the uterosacral ligaments. There's other ligaments called the cardinal ligaments, which are really more the bottom of the side support of the pelvis. And then there's connective tissue between the vagina and bladder, and between the vagina and the rectum, that hold everything in place. And then connective tissue at the bottom and musculature at the bottom, called the perineal body, which supports around the opening. So it's like a big suspensory system holding everything in place. It has the ability to move, kind of like your car's wheels can bounce up and down on the road, but it still holds the car in place. And so when all that starts to get broken down, and typically the first big insult in life is childbirth, then things go wrong. And the laser treatments can help. Ultimately, if it's severe enough, surgery. Musculature also is very important. So this is the pelvic floor muscles. The pelvic floor muscles act like a bowl or a floor in the pelvis. The bigger group of muscles, that we typically call them the Kegel muscles. The real name is the levator ani muscles. It's a group of 3 muscles that wrap around the urethra, the vagina, and the rectum, and hold everything else from coming out, and then allow, by dynamic movement, things to pass when you need to empty your bladder or move your bowels or have sex, right? And it's all supposed to work dynamically. And then there's the more superficial muscles, the perineal muscles, that's the area that typically gets destroyed during childbirth, between the vagina and the rectum. And those are more superficial muscles that kind of dictate the size of the opening of the vagina and the tension in the muscles at that superficial level, and also around the rectum as well. And then the vaginal epithelium is also important. So that's the skin in the vagina. And the vagina is skin. So there's often confusion that the vagina is mucosa, which is like the lining of the bowel or your mouth. And it's not. It's actually skin. It's the same stuff that's on the surface of our skin. The only difference is that it doesn't have keratin, that dead layer of skin on top that makes this skin tough. It is non-keratinized epithelium. But the point in terms of talking about the laser is that lasers have been used on the surface skin forever, right? Dermatologists, plastic surgeons have used lasers on skin forever. It's the same stuff, and that's why we started using it in the vagina, because the vagina is also skin. So it reacts exactly the same way as the skin on the surface of your body does when it's being treated. because it's the same. There is a deeper layer called the lamina propria. That's where the nerves and muscles are. The point of that is you just want to make sure that you're getting decent technology if you're doing this to get deep enough into that layer, because otherwise you don't get a lot of remodeling. So some of the cheaper, crappier models of lasers don't. Can you say crappy on Facebook? Okay, crappy. Okay, there's a lot of stuff I'm going to say tonight you can't say on Facebook. But anyway, don't go to some place that doesn't know what they're doing and has an Amazon bought laser. That's the point. So the clitoris. These treatments help clitoral function. Clitoris is a much more substantial organ than people think about. So typically the thing that people think about is just the glands, the little tiny part you could see above the urethra. But essentially it's like a small split penis. That's the easiest way to think about it. It makes sense. We all develop from the same stuff, right? We embryologically start all out the same and then divide up. Certain parts of us change over time and keep changing over time, right? For better or worse. And so there is a shaft to the clitoris, and then there's the crus and the corpus cavernosum, which run along the side of the vagina. And all of that is neurovascular tissue. And so when we're treating with the lasers or PRP that I'm going to talk about as well, it treats all of that, right? So that we get a better vascular response in the entire vagina, not just the glands, right? Because that would maybe it would definitely give better sensation, but there's a lot of other things that go into sex being positive that if we only treated that, it would be limited. All right, so childbirth, it's his or her fault, right? This is and this is why. So you can't get something that big through a hole that small and not cause damage. All right, you just can't. And babies are too big now. Without modern nutrition, a baby should probably be about 4 to 5 pounds. There was data from World War II, famine in the Netherlands, and the babies were in average 4+ pounds, and they tracked them over time, and they have the tallest people on earth. So there's no impact on neuromuscular development whatsoever. However, we as humans have gotten bigger over time, but not that much bigger, just a little bit bigger. And so our pelvises are just not big enough to get a baby that's 7, 8, 9, keep going, pounds out of that area without causing significant damage. And so you get stretching, tearing of the connective tissue, you get tearing of the skin, you get tearing of musculature, and then the most difficult thing to treat is you can get crush or traction injuries on the nerve, particularly the pudendal nerve. That nerve is here in the pelvis, and so it comes out of this bony canal called Alcott's canal, and at that level in the bone, it's kind of stuck in place. If anyone's ever seen a vaginal delivery, the tissue bows way out, right? Before the head comes out, that tissue is going way down, and what's happening inside is that nerve is being crushed up against the bone and also stretched. And its ability to recover varies. Some people recover very nicely. Most people are somewhere in between. Some people have really devastating injuries to those nerves, and they don't work at all. And what that means, that nerve goes to your pelvic floor muscles, the anal sphincter, the urethral sphincter, and the clitoris. And so if that nerve is substantially damaged, all of the above can be impaired, right? So, and it's not just a simple fix. Nerve, unfortunately, we do not have something that can just fix nerves like we have with connective tissue and things like that. Question.
Yeah,
you're out of turn, but allowed.
Is that what causes that ring of fire sensation during childbirth? Is that compression of the nerve?
No, that's your skin tearing.
Oh,
Yeah. So yeah.
thanks for being honest.
Yeah, no, it's so the pudendal nerve is a motor nerve. It is not a sensory nerve. So yeah, so no, but but yeah, that it hurts. No argument. um, so consequences, right? Losing support in the pelvis. The most common is the bladder coming down, and as the bladder and the urethra loses support, you can start having incontinence or losing control of the bladder. And you can also have the opposite. When the bladder falls down too much, it's very common not to be able to empty because gravity is now working against you. Annie touched on this, but the most common types of incontinence are stress incontinence, which is loss of support to the urethra, urge incontinence, which the technical definition is detrusor instability, meaning the name of the bladder muscle is the detrusor muscle. So if it's true overactive bladder, it's a neurologic dysfunction of the bladder muscle, or a combination of the two of those. And those two, or a combination of the two, make up 90% of female incontinence. The rest of the 10% is a grab bag of less common things. Ratio-wise, about 50% is stress incontinence. That is by far the most common type. So support issues. Mixed incontinence, about 30%, meaning you have a combination of overactive bladder and stress incontinence. Then overactive bladder is actually only about 20%, which is the opposite of what you would think based on the number of commercials you see on TV for medications. But you can't sell a medication for stress incontinence. They've tried, it doesn't work. So that's why you see all the commercials for that less common type of incontinence. In terms of what we had in the past, we've had watchful waiting, which is doctor speak for, what we said is, I can't help you, right? We'll just keep an eye on it, over-the-counter products, so pads. There's some like, pessaries that are over-the-counter, which just usually cause people problems. Some medications, so overactive bladder, there are medications. Most of the studies show they don't work a lot better than placebo. They have a lot of side effects. The the anticholinergics, which are the most common ones. So oxybutynin and Detrol. Most of the other ones that you'd be familiar with their names are all anticholinergics. Had just been associated with about 30-40% increased rate of dementia. So particularly in older populations, not something we want to use. Pelvic floor therapy, absolutely helpful. We have, like Annie touched on, we have the chair. I'm going to talk a little bit more about that, but also traditional pelvic floor therapy. The better you can get those muscles working, absolutely the better you're going to be. But it's inherently limited in terms of how much function you have. So if you truly have a nerve problem, there's only so much progress you can make. Or if you have prolapse that is really past the stage 2, there's only so much progress you can make by doing those types of therapies. And typically it's not enough once you're at that stage to really change your quality of life, if we're being honest, substantially. And then, historically, if that doesn't work, we go on to surgery. That's a pretty big jump, right? So we're just talking about stuff in the store or somebody helping you squeeze your muscles to surgery, right? And so where this fits in, where the energy-based therapies fit in, is in between that. Because the energy-based therapies help regenerate collagen, they help regenerate elastin, they help regenerate blood vessels and nerves in the tissue. And so it actually can reduce prolapse by about a stage, and it can get that tissue functioning better again, short of surgery. So in people with like stage 2 prolapse who are moderately symptomatic, it can make a substantial difference. If you're past that, it probably won't. So, all of these therapies have their appropriate place. But, if you're just leaking a little bit when you go for a run or something like that, this can be a fantastic option as opposed to having to go through surgery. And there's no downtime with this. So, all right, so we'll just talk a little bit more about the symptoms. So again, Annie touched on this. So GSM, or vaginal atrophy, burning, dryness, itching, more common UTIs, more common vaginal infections. Because you lose collagen in the tissue, it becomes extremely uncomfortable to have sex because the tissue will not stretch. And you lose, the other thing that happens is you lose blood vessels, the way the vagina lubricates is fluid leaking across the capillary beds, the blood vessels. And so if you lose blood vessels, you lose fluid, right? And especially when you are sexually aroused, those vessels are supposed to dilate and allow more fluid to cross. So once you lose those blood vessels, all of that goes away. Even no matter what's going on in here, you don't have the plumbing anymore to have that reaction, right? So this helps regenerate all of that issue. The other thing in terms of preventing UTIs, healthy vaginal epithelium secretes a glycogen, which is like a sugar substance that attracts the healthy bacteria, the lactobacillus. So when that healthy epithelium or healthy skin is gone, that stops and it allows the bad bacteria to grow in its place very easily. It also secretes an immunoglobulin, IgA, which binds up bacteria and gets rid of it. So like the most common UTI is E. coli. This is a blown up version of E. coli. They look nasty. And they have like these little arms on them that allows them to stick to the urethra and the lining of the bladder. And what IgA does is it binds them up and allows them to be expelled more easily, flushed out. A common over-the-counter thing that you can get is D-mannose. It does the same thing. So buy D-mannose. Don't buy the super expensive ones that are like $100. You can buy like a bucket of powder on Amazon for like $5. So in terms of atrophy treatments, we've had non-hormonal treatments with just mostly topical lubricants, which if it's mild, that definitely can help. Low-dose vaginal estrogen. Oral estrogen does not get to the urogenital tissues, right? So anything you take in your mouth gets metabolized by the liver before it ever gets to the periphery of your body. So it does help with certain symptoms, the vasomotor symptoms that Annie talked about, and those types of symptoms, but it does not help with vaginal tissue. So the only ones that help with vaginal tissue are ones that are put directly in the vagina or put under the skin or absorb very well through the skin. So creams can help to an extent, patches can help to an extent, pellets help enormously because they don't have the skin as the barrier, and then obviously, hormone directly on the vaginal tissue helps. Some people, it's messy. Some people don't respond well to it. Some people react to it. And also, there are people that are not eligible for it. So people have had estrogen receptor breast cancers or other hormone sensitive breast cancers, or rather any kind of cancers, are not candidates for hormones. People who have clotting disorders that are related to hormone issues are also not candidates. People that have had cerebrovascular accidents, other things like that. People who are smokers who are at higher risk. So there's a large population of patients that are not candidates for those types of therapies. And this treats that tissue without using any hormone, no risk. It's just purely a local treatment. There has never been an adverse event reported with these types of therapies. So huge benefit there. Vulvar dystrophies. Oh, where's my warning slide? Sorry, warning. Okay. We have to be careful with Mark Zuckerberg. So you're only allowed to show certain things on Facebook. I did. I swear I put it on there. I don't know why. All right. So next slide is okay. You're supposed to look at the flowers, right? Okay. So vulvar dystrophies. So what these are is a group of skin conditions that can really destroy the opening of the vagina and vulvar tissue. This is a severe example of lichen sclerosis. You can see this thick, inflamed tissue. The labia minora, so the inner lips of the vagina, are gone. The exposure of the clitoris is gone. The back opening of the vagina is gone. So unable to have sex, extremely itching, burning. It can be an absolutely miserable problem. The only treatment really that is somewhat effective, short of laser treatment, is a topical steroid or systemic steroid, which you can only use briefly. So those you know, one, the only thing a steroid can do is get the tissue to calm down, right? So it will basically stall the disease at the point that it is now. It will not make it better, right? So if the opening of the vagina is stuck together, the cream's not going to unstick it. If the clitoris is covered and you don't have any sensation with sex anymore, it's not going to fix that. But it can help with the itching, burning, etc. What the laser does is it remodels that tissue, so it, to a large extent, gets it back to normal. It gets rid of the fusion. It can re-expose the clitoris. It can help with the pain with sex. It won't help labia minora that have gone away come back again. Once that's gone, the only thing that can fix that is surgery. We can reconstruct labia minora if somebody wanted to, but short of that, it can normalize the tissue. This can actually turn into vulvar cancer if it's not treated, so it's not something to just take lightly as like an itchy skin condition. It's more serious than that. Sensory disorders, so lack of sensation with sex, traditionally have had really not any good treatments, right? So estrogen, progesterone don't do anything for sensation with sex. Testosterone helps in the sense that it hypertrophies or makes the clitoris bigger. So bigger target doesn't make it work any better, but it makes it bigger. So especially if you have a partner that's not quite finding it, maybe that helps. But that should be an Annie joke, not me. So, but it doesn't fundamentally change the way it functions. So what this does, and PRP, which I'm going to go into, is it actually remodels that tissue. So it gets new blood vessels, new collagen, new nerves back into that tissue, so you actually get that neurovascular tissue functioning better again. In terms of how it works, you have ablative, non-ablative, and fractional ablative and non-ablative treatment. So a vaginal treatment has to be fractional. What that means is we're only treating a certain percentage of the tissue at any given time. If you treat 100% of the vaginal tissue, you would create a fully raw surface and it would just fuse closed. So obviously that's a terrible, terrible idea, right? So when we do these treatments, the maximum we're treating is in the 20%, and that prevents any risk of any healing abnormalities. But because of that, if anybody's had these treatments with me, it's done in a series. It's not a one-time treatment for the vast majority of these problems. It is a series. And the reason for that is because we can only treat so much of the tissue each time. It has to be done a number of times to treat 100% of the tissue, but that's done for your safety. So we want to be effective. We also want to be safe. Radiofrequency also works. That works in a similar way. Mechanism of action for that is more bulk heating, but it also causes remodeling of the tissue. So new collagen, new elastin, new blood vessels, but not by putting little micron-sized holes in the tissue. It's by just heating the tissue to create a healthy wound healing response. What basically we're doing is neocollagenesis, so creating new collagen. Type 1 collagen is like a spring. So healthy young tissue, which my cheek will probably stay in the same place, but healthy young tissue is stretchy, right? So it's tight looking, but like you pull on it, it stretches, right? It has give. And that's what healthy tissue should do. When you lose collagen, it either has no give, or when you pull it, it stays there, right? So it doesn't have that dynamic movement to it. So we get new collagen back in there. We get new blood vessels, like we talked about, and that helps with the sexual response and also just general lubrication. It also causes growth factors. That healthy wound healing response that causes a cascade of growth factors to be emitted. And so that also helps with healthy wound healing. In terms of data, this was a large study that was initially done in the United States looking at lasers, and it showed over 90% success rate at 1 year. Another study looking in breast cancer survivors. So this is patients who are not eligible for hormones. it had equally good response at 1 year as a normal population, a non-cancer population. So this works equally well in breast cancer patients or other patients that can't use hormone as it does in patients without those risk factors. Radio frequency, very similar results, not quite as dramatic, but excellent results, extremely safe. Radio frequencies probably slightly more comfortable, but they both really don't hurt. In terms of stress incontinence, they have over 50% success rate. If you get into a more mild to moderate population, it gets up more like 80–90%, lasting up to about a year. So it does have to be repeated after about a year. In terms of topical estrogen versus a laser treatment, the laser works substantially better than vaginal estrogen cream in terms of alleviating these symptoms. They both work, but the laser works substantially better. In terms of lichen sclerosis, that was the skin treatment we're talking about. It also has a very high effectiveness rate, so satisfaction in this study was almost 97% in terms of alleviating those symptoms. In terms of the laser that we use the most often, so we were the main center for a 1 year, we actually have 3-year data now, randomized controlled 5-center study that looked at the technology that we have for the treatment of menopausal changes, so atrophy. And we looked at, this was a little more detailed study than most of them have been. We looked at a number of factors in what's called the Female Sexual Function Index. This is a validated questionnaire for female sexual function. And we had substantial, significant improvement out to a year in all of these domains. Vaginal Health Index, so this is looking at the health of the vagina, both in terms of pH, fluid, and a number of other factors. You can read them at the bottom. I'm trying not to have this take too long, but we again showed significant improvement out to a year in all factors. In terms of looking at histology, so biopsies, this is before and after biopsies. The light blue is collagen, and the red is blood vessels. And you can see 3 months after, there's substantially more collagen, substantially more blood vessels in the tissue. In terms of thickness of the tissue, so the thickness of the skin in the vagina, at 3 months, on average, it was 88% improved. At 6 months, 116%, and at 12 months, 153%. So substantial improvement in the vaginal thickness. No adverse events in the study whatsoever. And that's what we've seen with any of these technologies. As long as you don't shoot somebody in the face, they're going to be fine. And if you shoot somebody in the face, call it a day. Warning, another picture. We'll get that right next time. I think I downloaded the wrong version. Again, the hand pieces we have for the external work a little bit differently, but it can substantially improve lichen sclerosis. So this is a before and after of one single treatment. Our treatment protocol is 5 treatments. This is just after 1 treatment. You can see this thick, this is called leukoplakia, this thick tissue that's really where a lot of the inflammation is about 50% reduced just in 1 treatment. And the labia minora, which are the inside lips, in terms of seeing that kind of disfigured looking treatment or appearance, is substantially improved. Again, that's just one treatment. After 5 treatments, this should be pretty much gone. Warning. I'm just having fun saying warning. You can also use this to tighten the external tissue. So we can do a labia minoroplasty, which is reducing the size of the inside lips or tightening the outside lips in the vagina. Again, it takes a series of treatments. It's not as radical a change as surgery in terms of the substantial change. If somebody wants really significant change, we do cosmetic surgery, and that gives more change. But if you want to do something that tightens the tissue without any downtime, this actually can substantially improve or change the appearance of the tissue. The other thing we have is intense pulse light, which is using wider wavelengths that can also tighten the tissue. We use that primarily for the labia majora, the outside lips in the vagina. And you can just see some before and after pictures here in terms of how that tightens the skin. And that, again, lasts about a year. And then you just need a single touch-up treatment. You don't need 5 treatments at that point. You just need a single touch-up treatment to keep it going. So this really works in terms of improving the tissue. And when we talk about making things stretchier and then also making things tighter, it's a little confusing for people. You're like, how does it do both? What it's doing is making the tissue healthier, right? So it gets it into that healthy middle ground. It's not too tight, not too loose, has dynamic movement to it. So it's healthier, more youthful tissue. All right, any specific questions on that? The other talks are shorter. So, yeah. No. So sex doesn't either cause these issues or lack of sex cause these issues. If you don't have sex, sometimes your ability to relax initially can be more difficult. So if it's been a long time since you've had sex, having some pain initially is not uncommon, but a lot of that has to do with just lack of initial response, other factors, psychological factors, but the tissue itself doesn't change. Anything else? No? Okay, I gotta switch talks. All right. Okay, we're going to talk about PRP. So Annie talked about this a little bit. So this is called platelet-rich plasma. This is something else we use to improve the quality of the tissue. So similar idea, but it's used in like a more focused area, basically, or areas. So what platelet-rich plasma is it's growth factors and platelets that are derived from whole blood, so your own blood, and it's centrifuged off, and I'll show you a little more detail on that, isolating the platelets and the growth factors in the blood. This is not a new technology. It's been used in a variety of places. It's used very, very commonly in orthopedics to help regenerate, particularly cartilage, because it's hard to heal cartilage. And has been adopted into this space over the last, I'd say, 10 years. In terms of the way it works, it basically causes, again, a wound healing response and tissue regeneration, remodeling, and then the angiogenesis, neurogenesis, just like we talked about with the laser. In terms of safety, it is your own blood. It is as safe as the rest of your blood in your body. And we obviously are very careful with how we handle it. So, go somewhere responsible. Don't go to the neighborhood, whatever, and have your PRP done. There are some horror stories out there in terms of like people reusing needles and stuff like that. But obviously we don't do that. But beyond craziness like that, there's no risk of disease transmission, no risk of allergies, no risk of adverse events have ever been reported, because this is literally just taking a component of your own blood, concentrating at very, very high levels, and putting it back into you. That's all it is. So it is very different than stem cells. Yeah. But in a sense, it kind of works the same way. But stem cells are not your cells, unless you can isolate fat cells from somebody and use them as stem cells. but that's a very, very complicated, very expensive process. Most stem cells are taken from other cell lines, so from other people, or from a lot of times like fetuses or umbilical cords, things like that, and they're grown in a lab and then put into you. Stem cells are super expensive, and there's also a lot of risk associated with it. They're not FDA approved for this type of stuff. There's a lot of risk in terms of how do you turn the growth process off, right? So it's one thing to start growing tissue, it's another to control it. If you can't control it, it's called cancer, right? So stem cells are a little dubious in this area. So this has none of those types of risk. It's just things to stimulate your own healthy wound healing. In terms of how we prepare it, you just come in, you're getting a blood draw. So depending on the treatment, it's usually a 10 to 20 cc blood draw, and it's spun down. So we have a specialized centrifuge and specialized tubes that isolate the platelets and the growth factors from the red blood cells, and then we're able to use that. So this is what it looks like after it's spun down, and this is the stuff we're interested in here. And then there's a gel coat, and then the blood cells or red blood cells are blocked off. So we isolate the plasma. Most of the concentration of the platelets and the growth factors are going to be up against this gel coat right here. So what we do to further the concentration is we pull a little bit off the top before we actually mix it back up again. The very top is called platelet poor plasma, or PPP. Say a lot of P's. And by removing that, what you're doing is if you remove half of it, then you double the concentration of the platelets and the growth factors once you dissolve it back up into the rest of the fluid. And then that's what we draw up. So that's the platelet-rich plasma. So just in terms of the overall process, your blood is drawn, it's spun down, the platelet-rich plasma is obtained, and then it's injected into the tissue of interest, which in our case, most of the time, it's the clitoral structure, right? So this is for intimate PRP. We also use it for lichen sclerosis or scar tissue or anything else where we want to have a healthy wound healing response. But the most common one is for sexual function. It can be activated, meaning so platelets, right, are what starts the clotting process in our body. So if you get a cut, that's what goes there first and starts blocking stuff off. And so contact with collagen of any type activates this process. So once it's injected into your tissue, that whole cascade of healing is started. We can exaggerate that by using some chemicals ahead of time. What we use is the calcium chloride, and what that does, it basically just helps it stay in place better. It starts the clotting cascade so that the PRP gets thicker, and so when you put it into that tissue, it's going to stay in that tissue. It's not going to go anywhere else. So there's nothing hugely magic about the activation process, but it does help it have success in that it stays exactly where you want to put it. So we activate it. Not everybody activates it. This is just kind of a diagram of what happens. So you activate the PRP. It's put into the tissue, and it starts a whole cascade of healing. And depending on what you're doing, it basically, depending on where you put it, it differs on the tissue regeneration. So obviously, if you're using it in bone, it can cause osteoid or osteophyte production. If you're putting it where we're putting it, it's more collagen, elastin, blood vessels, and nerves. In terms of wound healing, it has been shown to substantially improve wound healing. In terms of gynecologic use, it has been used in a number of uses. It helps with all of these. I would say the most effective are aesthetic and sexual enhancement. The other ones, I would say, we see moderate to mild improvement. But for aesthetics and sexual function, it has been a game changer. This was the initial study that was done, so 2014, 12 years ago, just a pilot study seeing if this helped. This was done by Dr. Charles Runnels, who's in Mississippi, and he showed an 85 to 95% success rate after 2 treatments, and that's been reliably what we see. And then it has to be repeated once a year. Basically, the way it's done is we give a topical anesthetic onto the clitoral structure. It is numb. We then also do a block. So to make sure it's numb, once the surface is numb, we add a little lidocaine. That way you don't feel anything at all. And then about 4 cc's is injected into the G-spot, and about 1 to 2 cc's is injected into the shaft of the clitoris, and that starts the healing response. So those are our target sites. So the G-spot in the vagina, which is, if you're me, it's the urethrovesical junction, so it's where the urethra and the bladder meet. There actually is histologic data showing there are some branches of the clitoris in a lot of people in that area, and then also into the shaft of the clitoris. This was a larger study done by Dr. Runnels and a group of other people, showing similar results, no adverse events, and then looking at, all right, warning time. And then looking at lichen sclerosis, it's also shown significant improvement. Oh, see, it did work. Okay, I just didn't do a good job. There's my slide. Okay, I was happy with that slide. Okay, the way we treat lichen sclerosis, this is from an initial study. This looks kind of barbaric. That's not how it looks when we do it. But this is putting the PRP into that inflamed tissue. You can see the substantial from here to here, 1 week later, 1 year later, really very, very substantial reduction in the inflammation and the anatomy changes. So just with one single injection. It also can be used for, you're still on the warning, right? Okay. It also can be used for augmentation. So because it helps with any tissue that's injected into, if you inject it into a fat area like the labia majora, it will help regenerate fat tissue in that area. And so for people who want augmentation or more volume in the labia majora, sometimes with age or childbirth or weight changes, you lose volume in that area, and people don't like that. By injecting into that tissue, you get more volume back. So you can just see the before and after pictures in terms of, and all this is an injection in the office, and you can get substantial improvement in the volume. I guess, for lack of a better word, plumpness of that tissue for a very simple treatment. It also works for men. So I'm not going to go into details on that, but just so everybody knows, it also works for men. So it is called the P shot. All right, any questions on that?
How painful are the PRP
Not.
injections?
You feel nothing. Yeah. So we use the same topical as we do for the laser, and then I do. It's a clitoral block, but it goes through the frenulum, which is a tissue on the side, which isn't nearly as sensitive. And then the lidocaine just sort of leaches over, so you don't actually have to inject the clitoris directly. And it's super numb. People don't feel anything. All right. We'll move on if nobody has any questions on that. All right. We'll talk a little bit about the cell therapy that Annie talked about. Yep. We'll see you later. It will load. There we go. Okay. All right. So we talked a lot about connective tissue. We're going to talk more about muscles now. So this is something we use day in, day out, all day long. It's advanced pelvic floor therapy. HIFEM stands for high intensity focused electromagnetic therapy. And so in terms of these types of therapies, right, nobody likes taking care of this stuff, right? You know, we're busy, but we know nobody actually wants to be here, right? And we try to make it as pleasant as possible, but you know, we know that. But you know, this therapy really kind of hits the mark in terms of it being completely non-invasive, non-surgical. You don't even have to get undressed, right? It's completely non-invasive. It's discreet. There's no downtime. There's no pain, and that also helps people be willing to keep up on it, right? So what we're talking about treating is the pelvic floor muscles here. Again, I showed this diagram here. So there's two levels. The advantage of the HIFEM therapy is it basically treats everything from the level of the seat to your belly button. There is no other technology that does that. Other physical therapy type devices that are called electrical stimulation or e-stim are little plastic probes that go in the vagina and have EMG or little metal contacts on them. They will treat the muscle that's in direct contact with the vagina, which is the pubococcygeus muscle, right? This muscle right here, and that's it. That's the only muscle it treats. That's an important muscle, but there's a whole lot more muscles in the pelvic floor. There's three muscles in the levator ani themselves. So there's the pubococcygeus, iliococcygeus, and coccygeus. And then there's the perineal muscles, which are the bulbocavernosus, ischial, I got to remember myself, ischial tuberosity, and the anal sphincter. And then there's the obturator internus complex, which are deeper muscles in the pelvis. And this gets all of that. It also gets the iliopsoas a little bit as well. And so we see a lot more improvement in this because it's getting a wider array of musculature. In terms of the way they're supposed to work, right, most of the time these muscles have some tone on them and they're keeping stuff from falling out of the body. And the way they do that is like a sling. So that muscle slings around from the pubic bone behind the rectum, the urethra and the vagina would be in between there, and around to the other side, and it's pulling it forward. So it creates a kink and prevents everything from coming out. So when you lose tone in that muscle, now that angle straightens out and everything can come out. So it overloads the connective tissue, and then over time it just keeps getting worse and you develop prolapse. So normally, because of that kinking effect, the angle of the vagina, as opposed to that diagram you saw earlier in the body, or most diagrams where you just see it kind of going straight into the body, the real way the vagina is oriented in the body is the lower third is fairly straight in, and then the upper 2/3 are almost straight back. And that's because the muscle is pulling forward at this level, causing everything to fall back towards the tailbone area. And that's what prevents everything from coming out. And so when that's working well, it prevents prolapse or other dysfunction. When it's not working well, you lose that protection. So biofeedback, common thing we use is what I was talking about, the e-stim or electrodes. It's definitely better than nothing, but it's not as good as what we're talking about. This is the typical instrumentation for it. So this is the chair. You don't sit like that on it, sorry. you cannot sit on it in a ladylike, but nonetheless, it's still pretty non-invasive, you know. So, so it is FDA approved for the treatment of incontinence in both genders, and for sexual function related to vascular insufficiency in both genders. So it also works for men, commonly used after prostate surgeries. And yeah, so take comfort in the fact that it's fully FDA approved for these things. Basically, the way it works is a big magnetic coil in the seat of the chair. So it's like a super kind of MRI machine, but it forms a very, very focused electromagnetic field just in that tiny area, as opposed to like an MRI, which is like all over the room. That's why you have to be careful with MRIs. This is just focused in that little area, and that electromagnetic pulse causes the nerves to fire and then contracts the muscle in turn. And so what you get is what are called supramaximal contractions. So the muscle is contracting harder and faster than you could ever do on your own. So over that 28-minute period, like Annie said, you have 11,400 contractions. Those contractions are harder than you could ever do on your own. You compare that to regular pelvic floor therapy. Most people in a half an hour session will have 200 contractions, and they're only as hard as you can do it. And you're not there because you're doing such a good job, right? So you know, it's limited in terms of what it can do. This doesn't rely on your body to your body's limitations, which is fantastic, right? Because you want to make progress. So this is just kind of, this is what on the left side, that's what normal contractions look like. The other ones are what the Emsella supramaximal contractions look like. So much, much harder, much faster, and it's making it stay at that contracted level for longer. This is just an ultrasound kind of showing the changes that you might see in the muscle. So this is an ultrasound, that's the bladder, but this is the pubococcygeus muscle here. This is before treatments, this is after treatments. You can see how much thicker that muscle got. So just like the other skeletal muscles in our body, you work them out, they get bigger and stronger, right? So this same thing. So we do have ultrasound evidence showing that muscle actually does get bigger. It's a weird slide, okay, so, but this is the position you're supposed to be in the protocol. I don't know why they picked this picture, but it's a guy with no hair and no genitalia and a red bar. But that's about how you're supposed to sit. So your knees at 90 degrees. You want to try to hold that position. we have a table in the room to help you kind of hold that position, because it will, you know, so it's kind of like a little desk table to help you stay in the right spot. But otherwise, it's pretty easy. So you just have to get properly positioned. That actually does matter. You can sit on this wrong. Like, so if you're not quite in the right spot, and we will take a little time to get you in the right spot, especially with the first session. If you're not in the right spot, you're not going to be stimulating the right muscle. You don't want to be wearing really thick pants or pads or anything like that, because it does have to get to those muscles. But after that, you just have to stay in that position, and you're good to go. So again, advantages: non-invasive, super physiologic. It's only a 3-week process versus typical physical therapy, which is 3 months. And it lasts 6 months, and then you just need touch-up treatments. So 2 sessions every 6 months keeps it working. Candidates, so like I said, it works on both genders. Mild to moderate incontinence, doesn't matter what kind of incontinence, it helps all incontinence. It helps with laxity, it helps with sexual dysfunction, helps with bowel control issues, and helps with post-op. We use it very commonly in our post-op patients to help the muscles get going again. And also in high-tone patients, so patients with spastic muscles. The common term is vaginismus, or high-tone pelvic floor disorder. It's a little, again, contrary to what you would think, but what it does is it exhausts the muscle to the point where it lets go. So it's almost like acupressure, if you've ever heard of that. You put pressure on a muscle until it finally lets go. This stimulates the muscle so much that it just can't stay in that high tone position anymore, and it finally lets go and starts working normally. It doesn't work on everybody, but when it works, it really works. And for these people, it's huge, because this is non-invasive. Anything invasive in somebody with vaginismus is really difficult to do, because they have so much pain with any insertion. So this avoids that. This is a study that I did with Dr. Samuels in Louisville, looking at outcomes using mild to moderate stress incontinence. So we had 95% improvement rate, and that was maintained over 6 months. So consistent data. This study has been replicated a number of times. We did a larger study. So this was a multi-center randomized prospective study out to a year. And it was comparing Emsella to the Harvard Deaconess pelvic floor therapy protocol. That was one of the centers. And in terms of that, it did substantially better. So we had significantly better outcomes, and we had way, way higher adherence to the therapy. Almost nobody dropped out, whereas with regular pelvic floor therapy, the dropout rate was fairly substantial. Anybody who's ever done pelvic floor or any type of PT knows it's hard to stick to it, right? It's just a lot. All right, so never mind the picture, but so exercise also helps. Just exercise in general, right? All of this is connected. And we do have a core to floor program. So we have another machine that uses similar technology. It's also a high fem technology, and that can get your core, so all the core area, the buttock area, and that can work in conjunction using the same technology but in different areas of the body. And we call it core to floor because you're kind of treating that whole area. So, all right, questions on that? Sure. These are out-of-pocket expenses. Yeah, so insurance does not cover these types of therapies. Unfortunately, and this could be an entire night, I could go off on this, but unfortunately, our government and insurance companies don't cover really anything having to do with sex for women. And yeah, so if you put SEX and insurance together, you end up with $0. Yeah, so that unfortunately is, yeah, so those therapies are not covered. Question? The Mcella is just for your pelvic floor. Are you talking about the last one I showed, the M-Sculpt? Right, yeah, so that treats the rest of your body. So I'd say the best place, the places where it really excels are the abs and the buttock and that whole core area, but it also treats your legs, your arms. It does not. We do have another machine that does help with cellulite, but that does not help with cellulite. No, it's a combination of getting the muscles a lot stronger, and then it has radio frequency, which tightens the skin over the muscles. So it does tighten the skin, but what cellulite is it's fat cells, and then there's little connective tissue things that are tethered, meaning like they're kind of stuck down. So it creates like this dimpling effect. So the way that cellulite treatments work is by breaking up that dimpling. So this particular technology doesn't do that, but there's other technology that does. The M-Sculpt? Yeah, because that's postural. So yes, it would. Yeah, because like, you know, when you're not holding yourself correctly, that usually has to do with a mismatch of ab and lower back strength, things like that. Yeah, so it does reduce fat, but so it's, cellulite is different, right? Cellulite, you can have thin people that have cellulite, right? Because the reason why women get cellulite more often than men is because the thickness of the subdermal or of the connective tissue under your skin is not as thick. So we have thicker skin. That's why we can take insults better. So, yeah, exactly. Well, we have to because we're the ones that are doing the asking most of the time. So, you know, we get used to it. But I don't talk about money. We got people that can talk about that. So, but yeah. So it does reduce fat, and it gets the muscles a lot stronger, and it tightens the skin. But cellulite is a unique aspect to this that needs a specific treatment.
How long is the treatment?
Half an hour. Yeah.
For how long?
For this, it's four sessions. Yeah. All right. Well, we're on to the last talk. This one's a little different. Yeah, I'm
Is
listening.
this our phone video?
The talks.
Yeah, go back and watch it later.
We can. Yeah, we could post it. We're talking about that. I don't think we have yet, but we will be. Yeah, either she.
Okay.
Oh, you're welcome. All right. Have a good night. All right, we're just going to talk a little about robotic surgery. This is a quick talk. In general, the advantages of laparoscopy, which are little tiny incisions in the belly with tubes that are put in, is a lot less postoperative pain, shorter a hospital stay, faster recuperation, better cosmetic results. You can look around actually a lot better. And it has applications for remote work, although no one's ever really done that yet. When robotics first came out, I was still at the University of Pennsylvania, and we actually did sheep surgery in Pakistan from Philadelphia. Didn't work. And that was because we had about 1.2-second delay in the satellite relay. And 1.2 seconds when you're trying to operate is huge. So that we quickly abandoned that. Someday it will be possible, but it has to be instantaneous. So the way the robotic system works is you have a cart over the patient, and then you have the surgeon console, and then you have what's called a vision cart, where the other people in the room can see what's going on. The advantage is that the robotic instruments, as opposed to what we call straight stick laparoscopy instruments, move like a human arm. So straight stick laparoscopy can move in, can move out, can turn, can open and close. So it has limited freedom of motion. A robotic instrument has an elbow, has a wrist, and can rotate as much as my arm can rotate. So you can do very, very complicated procedures through extremely small incisions. And so that has really revolutionized how we treat a lot of these problems. Deep pelvic surgery. So in women, what I do, sacrocolpexy, the most common one being your big complicated reconstruction. In men, radical prostatectomies are probably the most common one, where you're deep in the pelvis having to do complicated things. This has really revolutionized our ability to do it. We used to have to do big, massive open incisions. You'd be feeling like a truck ran over you for a month. And outcomes were good, but obviously a lot more difficult recovery, and then there's risks associated with that difficult recovery. We've turned that now into actually a faster procedure, and one that is almost outpatient or just one night stay in the hospital, and has a higher success rate than the open version, and much, much, much less risk of complications. In terms of what we're seeing, I actually see in 3D when I'm operating. And so I can see in magnified, focused 3D. So I can see better than I could see if I was standing right over somebody's abdomen, because I can move that camera right down on top of where I'm operating. And it's in 3D. It's not 2D like regular laparoscopy. So you have full depth, full definition, very high def. And so it allows us to see better, allows us to move better, and keep extremely small incisions. So that, is like a C-section type incision. That one honestly looks small compared to what they normally would be, compared to 8mm size incisions with a robot. In terms of what I use it for, mostly it's complex vaginal prolapse. So losing support. This is an extreme example. This is it's called complete procedentia. So this is the cervix. The uterus is in here somewhere. Bladder's up here, rectum's up here, and this is all the vaginal skin. So it's all just come out. Warning. Okay. I'm gonna get canceled. But anyway, in any case, that's, this is an extreme example, but this is what we use the robot for most commonly. The old techniques were vaginal approach procedures, which I still do plenty of vaginal surgery, but we don't use these types of techniques. The traditional technique was tying connective tissue back tighter together. That has terrible outcomes because you're taking bad connective tissue and you're just sewing it back together again. So those fail half the time after 2 years and over 70% of the time after 5 years. So what we're doing instead is we're giving permanent reconstruction between those structures, and that has a much higher success rate. So this is an example of what we do with a robot. We use a graft that's kind of shaped like a Y. One arm goes between the vagina and bladder, one arm goes between the vagina and the rectum, and the other one attaches the ligament over the tailbone. So it brings the top up and fixes the front and back in one step. And again, this is the way the room is set up. Jane is actually my surgical assistant, so she's at the table right here. She was probably the one saying no to everything. And I'm over there, and everybody is working in coordination with each other. In terms of other advances that we can do, one of the things that actually there's suture that doesn't require knot tying, and I've adopted that for the sacrocolpopexy. The advantage of that is, one, it makes it a lot faster. Using a traditional technique where you're tying individual sutures, attaching the graft to the vagina can take about an hour. Using this technique, it takes me less than 10 minutes. And the other advantage is this is absorbable suture, so it lasts about 3 months and allows the graft to grow in place, but then the suture goes away. The traditional technique uses permanent suture, so it's there all the time. So over time, if the vagina got thinner or something changed, that suture could become a problem. And with this technique, it's gone, so it's not a problem. The other thing in terms of robotics is essentially what you're doing is you have a computer in the room with the surgeon and with the patient. And what that does is it removes a lot of human limitations in terms of what we can do. So one is obviously the size of the holes, because my hand can't fit through a hole that small. The other is how we see. And so we can actually see in different wavelengths. So this is the sacrum. This is where I'm attaching the graft to hold the top up. There's a blood vessel that runs down there. Not a particularly big blood vessel, but it comes right off the aorta. So it's under a lot of pressure. And if you hit it, it bleeds a lot. Not that I ever hit it, right? Nope. Yep. Okay. So, but it can bleed a lot. We actually have a technique. So use it's a dye called indomethacin green, and if you look under a laser wavelength, it makes that dye light up. So you can actually see that blood vessel before you ever make any incisions. So if there's any question about where it is, or you're just worried about the anatomy in general, you can switch how you're looking at things and make things stand out more obviously. Some other advances that are coming down the pike with it is like in cancer surgeries, being able to superimpose CTs or MRIs on your surgical field. So if you're trying to remove a cancer, you can actually see where it is on the imaging while you're actually operating live on the patient, things like that. So it makes huge advances in terms of how we can think about this stuff. Morning. Okay, that one I got right. Okay, so all right. So just some before and after pictures. So again, an extreme example of prolapse. This really does happen. This is after. So this is immediately after. So you can see the difference in terms of the anatomy. So that's the procedure that was done. Primarily, it's the sacrocolpopexy, but it also had a hysterectomy, a sling, which is for incontinence, and a vaginoplasty, a labiomanoroplasty. So those are cosmetic procedures that also can be done at the same time. And you can see the radical difference in the change, right? This is another patient. This is before. She had a robotic procedure as well as a cosmetic procedure. And then this is 3 months afterwards. So again, very, very substantial difference. And then this is this is more, we don't have as good an internal look, but looking at the outside, robotic and cosmetic surgery. And then this is 6 months post-op. So you can really make substantial differences when people just aren't happy with their tissue or have substantial prolapse. All right, that's it. Thank you. Questions?
When you're doing the surgery for the prolapse, your technique is because I believe studies show
Yeah. So that's a great question. The sacral colpopexy, that procedure we were just talking about, does require hysterectomy. That doesn't mean you need a hysterectomy in general, but I'll just go back. The reason for that is because of just the direction we're operating. Let's see, I got it right here. So this particular technique is coming down, right? And so and this is somebody that already had a hysterectomy, but if they had a uterus, the uterus is here. And so it's just for this technique, it's in the way. So if we do this technique, a partial hysterectomy is required. However, I am a big proponent of uterine preservation with prolapse procedures. A vaginal approach procedure where we also use grafts and have a very, very high success rate, over 90% using collagen grafts. And that's another technique that I've created and talk about that one tonight. Keeps the uterus in. And so that one does not require hysterectomy and also works extremely well. It's almost as high. It's not quite as high, but it's almost as high. Any other questions? Nope. All right. Well, thanks everybody for coming out. If you had questions for Annie, she's in the back here too. So, and then we got goodies, and you can look around at stuff if you're not too worn out by all the talking, and we'll go from there. All right. Well, thanks.
If anybody's interested in checking out the insult or the Emsella, I'll take you on